Welcome to the Brain and Body podcast with Allegra Foxley, where we discuss a holistic approach to healing and health.
Hello, I'm Allegra. I'm a trauma-informed body worker, so I help people to recover from post-traumatic stress disorder, otherwise known as PTSD, by rebooting and regulating the nervous system using conscious and subconscious movement. Now, what I teach can also have a transformative effect on managing premenstrual dysphoric disorder, otherwise known as PMDD, premenstrual exacerbation, otherwise known as PNE, and premenstrual tension, otherwise known as PMT. Do you know that women with PTSD are 8.14 times more likely to be diagnosed with PMDD, which is a psychiatric disorder that occurs due to the fluctuations of the female sex hormones, which is what we see in the menstrual cycle, resulting in severe premenstrual tension. Women with PMDD are almost 7 times more likely to attempt suicide than those who don't have it. It's a serious condition. Last September, I gave a talk at the Nutritious Minds event in London about how trauma disrupts the female body. And at this event, I had the pleasure of meeting Dr Ghazala Azizi-Scott, who's the clinical director and specialist in women's integrative health, functional medicine and bioidentical hormone balancing at the Marion Gluck Clinic in Harley Street, London. She did an absolutely fascinating talk, and I'm thrilled that she's agreed to come onto this podcast today to talk about PMDD. So, Dr Ghazala, over to you.
Thank you so much, Allegra, for inviting me to the podcast. I thoroughly enjoyed your talk as well. And I'm so interested in trauma-informed care. And I think it's so important that practitioners, particularly conventional practitioners, become aware of how important a trauma-informed approach is to all sorts of medical problems. I did my first degree in neuroscience, medical ethics and law at Cambridge. So I'm a bit of a geek. I enjoy the science behind medicine. And then I did clinical medicine at Oxford University. And then I trained as a GP. So I was a family doctor, a partner in a practice in West London for about 23 years. And around 2019, I thought I need to sort of do something a bit different. And I started training in bioidentical hormones. And I was totally fascinated by the world of bioidentical hormones and compounding medications, personalised medicine. I think personalised medicine is so important, and looking at each individual. And I started working for the Marion Gluck Clinic, and then I also at the same time started training in functional medicine. So I went to the States, to Seattle, and I did the introductory course with the Institute of Functional Medicine, and I was hooked. And I thought, oh my God, this is the approach to medicine that I've always been interested in. I've always been interested in the mind-body connection. And actually, here's a system of medicine that actually reflects what I've been thinking all along. And also the concept of looking for the root cause of any medical problem is also something that I've always been interested in. You know, I'm very curious, like, why is that happening? Why is that happening? I don't like sort of just thinking, oh, let's just give you a medication, a pill for every ill. You know, I like to look at what's happening, appreciate the complexity of the human body, appreciate that the psychological impact of our childhood, lifehood events, how we're living now has such a profound impact on our physical illness, and really finding an integrative solution that's going to support the patient. You know, conventional medical approaches are important, but the integrative approach where you're looking at other modalities to help support a patient are also so important. So I then left the NHS 2 or 3 years ago, and I became the clinical lead and then the clinical director of the Marion Gluck Clinic. And it's a very unique clinic because we specialise in bioidentical hormone treatments. We have a specialist pharmacy attached to our company where we compound the medications, and we also have the Marion Gluck Training Academy where we teach other practitioners how to use bioidentical hormones. And what's fascinating, so I teach the 2-day training at the Royal Society of Medicine. We do it twice a year, and the last couple of times we've had perinatal psychiatrists attend our training. And this is amazing because finally, it's not just, bioidentical hormones and compounding is not just the private sector. Now, people in the NHS, consultant psychiatrists, are recognising that amazing link between hormones and our mood, and actually, thinking outside the box. We don't need to have a label and a psychiatric medication for everything. We need to look at what is the underlying cause of this patient's problems, why is it happening, and what are the most effective treatments that address the root cause rather than put a sticking plaster over the symptoms.
Yeah, I mean, I have to say it's a refreshing outlook, actually, because I just didn't think that my doctors had enough information and that they realised that link between trauma. But, as you know, there are many different causes of premenstrual dysphoric disorder.
So PMDD is a severe form of PMS, or premenstrual syndrome, and it causes a myriad of emotional and physical symptoms each month during the week or two before the period starts. A lot of women have recurrent mild symptoms of PMS, but with PMDD, the symptoms are intense and seriously impact on the ability to function. And the prevalence is about 3 to 5% amongst women who menstruate. Now, it depends on how correct the diagnosis is when it's made. It depends on geographical variation. There are cultural factors. In many cultures, menstruation is really stigmatized, so people don't want to discuss anything that's linked with their period. And in 2019, the WHO gave it a classification, and they said that it is an endocrine-related mood disorder, and it is a depressive disorder. So it now has a WHO classification, and hopefully that will give it a little bit more gravitas amongst the medical profession, that it really is a thing, and that actually it has a huge impact on women, and that the correct diagnosis is so important. Now, the thing is, very often women have their symptoms in the luteal phase, and the diagnosis does depend on also the symptoms lifting after the menstrual cycle, but it can coexist with so many other psychiatric conditions. So actually to work out that actually my symptoms get worse in the luteal phase, but I kind of have them all year round anyway, is quite a difficult diagnosis. A lot of people don't see that cyclical variation that means that there's a hormonal link until they map it out, or they speak to a qualified healthcare professional who really understands and who really takes a detailed history about what's going on and thinks outside the box. So I think that's really important. And I think for any woman with PMDD, a coexisting psychiatric evaluation is really important. So I think, practitioners who deal with women with PMDD need to have a good understanding of psychiatry and underlying psychiatric disorders that these women can be suffering with as well. And it's not just psychiatric disorders that are exacerbated by hormonal fluctuations. IBS, migraines, endometriosis, these things are also exacerbated by hormonal fluctuations, and then they have an impact on your mood. So, premenstrual exacerbation occurs with many things, because hormones, they're not just about reproduction. We realise that hormones have such a massive role in the body. Now, the link with mood disorders is the link with hormones and neurotransmitters, but hormones also have such an impact on inflammation, on your immune system, on so many different things. Your body has 300 different receptors for estrogen. So we have estrogen receptors in the brain. All of the sex hormones are neurosteroids. There are receptors to those sex hormones in the brain, and also the brain cells also produce sex hormones. So they're incredibly important for our brain and for our mood, so we can't avoid this. And certainly, when we see women with perimenopause, one of the main symptoms they present with is mood disorders secondary to progesterone deficiency. So a lot of women will be presenting with insomnia, with anxiety, with overthinking. So there is a big link between hormones, neurotransmitters, and your mood.
Yeah, absolutely. Do you want to talk more about the hormones and what happens in the luteal stage with progesterone and cortisol?
Sure. So in the menstrual cycle, we have a fluctuation of our hormones, and in a natural menstrual cycle, in the follicular phase, we have estrogen levels gradually rising to approach ovulation. At ovulation, estrogen levels are at a peak. So we have peak estrogen levels at ovulation. The luteal phase is defined as the second half of the cycle, which is, for most women, between days 14 and 28. And in the luteal phase of the cycle, we have a surge in progesterone. Okay, and this surge in progesterone prepares the endometrial lining for a potential fertilization and implantation. So that's the function of the progesterone. It stimulates the growth of the endometrial lining. Now, progesterone is our happy hormone. It is our natural, calming, soothing hormone. This is why for most women in pregnancy, they feel much, much better because they've got high levels of progesterone. And with postnatal depression, that sudden drop of progesterone is what can trigger off postnatal depression in vulnerable women. So progesterone has this soothing effect through its actions on the GABA receptors. So the GABA receptors in our brain are the kind of brakes on our nervous system, and GABA is our major inhibitory neurotransmitter, so it calms the body down. So progesterone stimulates GABA receptors. Now, with a normal menstrual cycle, there's a normal stimulation of the GABA receptors to produce by a metabolite of progesterone called allopregnanolone. So allopregnanolone has a nice soothing effect on the GABA receptor in a woman who doesn't have PMDD. And the GABA receptor and GABA have anxiolytic properties, anesthetic properties, and antidepressant properties, similar to alcohol and benzodiazepines. So this is our natural tranquilizer. But in a woman with PMDD, there is an aberration in the GABA receptor, and there's also a decreased amount of GABA produced. So the aberration in the GABA receptor means that this effect of soothing and calming is taken away, and actually it can sometimes be that the decrease in GABA levels and the decrease in the GABA receptor actions then have the opposite effect of causing negative mood states. Now, it's a simplistic view because nothing is caused by one thing alone. So women with PMDD have an abnormal GABA receptor function, but there are so many other factors that feed into why a patient gets PMDD.
I know that some women with PMDD have a desensitivity to the hormone melatonin in the luteal stage.
Yeah, I mean, it's so multifactorial. Yeah. So, I mean, also, it's our sleep hormone, but also melatonin, we now know, is a very powerful antioxidant. So decreases in melatonin levels, will have an impact on inflammation levels in the body, and that can then have an impact on our mood, because we have a link between inflammation and the brain. So inflammation in the body can cause neuroinflammation in the brain, and neuroinflammation also increases our risk of mood disorders. I mean, it'd be really interesting to also talk about some of the other causes of PMDD. So we know that there's a genetic susceptibility. So when we have family and twin studies, the hereditability range is between 30 to 80%. Now, there's an estrogen receptor alpha gene that's linked with emotional arousal that also can be affected in women with PMDD, and there are also serotonin gene polymorphisms in women with PMDD. So there's a genetic susceptibility. It can run in families. Now, we talked about the impact of low levels of progesterone and its metabolite allopregnanolone. The other thing that has an impact is low estrogen levels. So we know that estrogen correlates with serotonin levels in our brain, and it has an impact on multiple neurotransmitter symptoms. And we know that women with PMDD have an extra sensitivity to fluctuations in our natural hormones of the body, both estrogen and progesterone. There are also structural and functional differences in the brains of women with PMDD, and there's lots of imaging studies that have confirmed this. So we have a difference in the amygdala. So, Allegra, you've talked about the amygdala in previous podcasts, where the amygdala is the fear centre of the brain. So we have a heightened fear response. There are also changes in the prefrontal cortex, which affects our sort of executive function and our cognitive function. And the thing that I'm so interested in is the HPA axis. So we know that how the HPA axis is programmed from early childhood to adverse childhood events to current psychosocial factors has such an impact on our general health. So when we're looking, I see so many women in the functional medicine space and in the hormone space with complex problems across multiple systems. And we know that all our hormone systems are linked. So it starts with the adrenal axis. So the hypothalamus and pituitary make up part of the hypothalamic pituitary axis. We know that the hypothalamus and the pituitary are the sort of master controllers of our endocrine system, and we know that the thyroid gland, the pancreas, the adrenals and the sex gonads are all interlinked, and an impact on one hormone system has an impact on the other, but the master controller is the cortisol axis. So our nervous system and our cortisol patterns are very, very profoundly influenced by our childhood events. So when you're a child and you have an adverse childhood event or you have a negative environment that you're growing up in, we rely on our immediate caregivers to give us care that calms our nervous system down. So when you fall over, you hurt your knee, your cortisol level goes up, you need your caregiver to give you a hug, tell you it's going to be okay, and then your cortisol levels go down. So with any events that result in increased cortisol levels in a child where they're not being co-regulated by their care worker who calms them down, tells them it's okay, it's safe to feel stressed, but we can calm ourselves down, we can self-regulate, we can calm our nervous systems down. Unless children are taught this through example and through co-regulation, an persistently increased cortisol level in children is very harmful to their body, because cortisol is our fight and flight hormone. It increases the amount of glucose released into our circulation, it increases the fight and flight response, and this is very negative. High cortisol levels damage the developing brain. High cortisol levels will damage the hippocampus, which is the main memory centre. And this is why children with adverse childhood events can't remember what happened to them. So in a way, it's a protective mechanism, but in another way, it's also how their brain responded to those high levels of cortisol. So what then happens is that the body switches off cortisol production in many different ways. So it can actually result in less cortisol then being available to the tissue. So if there's a high level of production from the adrenal glands, the body will work out compensatory mechanisms to hold on to that cortisol and mean that there's less available to the tissues. But then if there's less available to the tissues, we then have a decreased cortisol state or a low cortisol state, which also isn't good for the body because cortisol is needed for survival. So with all of our hormones, we need a balance. We need the hormone levels to go up when we need that physiologically, and we need those hormone levels to go down when we need that physiologically. We need that perfect balance in all of our hormone systems. So if cortisol is dysregulated, our body interprets this as a survival state. I went to an amazing conference in Miami last week on bioidentical hormones, and there was an amazing speaker, Dr Ghazala, who said, when you walk into a room and you see a tiger, do you think I need to run, or do you think about who I'm going to have sex with tomorrow? And I thought that was a very funny analogy of actually when we're in the fight and flight mode, all we're thinking about is survival. And our bodies then
our body prioritises what we need.
Our bodies then dial down the sex hormones. So our bodies are saying you're not in a fit state to reproduce at the moment because you're in fight and flight. And so cortisol, actually, all of the sex hormones and cortisol, they're all steroid hormones. They're all very, very closely interlinked in terms of their structure. So if you've got high levels of cortisol flooding your system, one of the other ways the body protects you from the impact of sex hormones is for those cortisol molecules to sit on sex hormone receptors. I had this other quote that said that cortisol is the tart of hormone receptors. It just goes and attaches to whatever it can. So the cortisol then attaches to the receptors that would respond normally to sex hormones, and then makes the impact of those sex hormones much less. So this is all survival, this is all protective. But if these situations go on uncurtailed, then our bodies get hardwired into these patterns. So we get hardwired into either high cortisol states or low cortisol states, and our bodies aren't able to have that lovely regulation or homeostasis that's so important for hormonal balance. And this is where the problems begin.
It's interesting because actually women who've been chronically stressed, so chronic prolonged accumulative stress, they will have had higher levels of cortisol than is healthy for a prolonged period of time. Now then, often is the case that it does tank, so cortisol production tanks. The brain then panics and makes an adaptation to the mitochondria hormone receptor, increasing sensitivity to cortisol. So even if you've got low cortisol levels, your hormone receptor sensitivity has increased. So you are still being affected, which I think is interesting. And talking about those adverse childhood experiences, the neural pathways between the amygdala and the neocortex aren't actually formed until the age of 11 or 12 years of age. So the neocortex obviously is fundamental in emotional regulation. And that's why people further down the line struggle to emotionally regulate if they haven't had that caregiver at that time.
Absolutely, absolutely. And then, you know, one of the things we've discussed is why is it that women with PMDD are more prone to other illnesses? And, you know, it impacts their quality of life. It also impacts their physical health. So women with PMDD, with this aberrant cortisol pattern, it also triggers inflammation. And we know that inflammation is the basis of so many chronic diseases. Inflammation and high cortisol levels also damage the very delicate lining of the gut. And this disruption of the gut lining can result in things like leaky gut. If things that your body should not be exposed to are then exposed to into your bloodstream through the leaky gut, then that causes an immune response. So we then have an abnormal immune response as well. So this can then predispose women to autoimmune conditions. We know there's such a big link with trauma and autoimmune conditions and trauma and cancer. But abnormal cortisol patterns have a profound effect on our overall physiology. So it's so important. This is where I think that, you know, people who talk about the importance of our early years, how we can help parents support their children better, how we can prevent childhood trauma, it has such a massive impact on the body and, you know, physiological function in later life. You know, so many authors like Gabor Mate talks about the impact of adverse childhood events and subsequent illness. Bessel van der Kolk, he talks about the body keeps a score. So it's so well recognised now that adverse childhood events do result in impaired physical health in later life, and the connection is the HPA axis and the cortisol patterns. That's where the root cause of that connection lies.
Yeah, it's absolutely fascinating. And that's why I've set up this podcast, because so many different factors that can affect our health.
Yes, definitely. And the other thing is women with HPA axis dysregulation, with a sex hormone dysregulation, they can actually become quite estrogen dominant. So cortisol really has an impact on progesterone. So progesterone levels are often lower with abnormal cortisol patterns, but estrogen levels can then be correspondingly higher. So the body can go into what we call estrogen dominant modes. And estrogen dominance is linked with conditions like endometriosis, PCOS, fibroids. I have so many women I see in the integrative women's health space that have endometriosis that again have had a lot of childhood trauma. So that childhood trauma, we know that endometriosis is linked with estrogen dominance, inflammation, and abnormal cortisol patterns, and gut dysbiosis. So again, we see all of those links. And that's why it's so important to have a functional medicine approach to someone with PMDD, where you're looking at all of these factors, and you can really have an individual understanding of what is driving this patient's symptoms, what is the cause of the PMDD. And then if you can work that out, you can actually then support them with a personalised treatment plan as to what might make them feel significantly better.
Yeah, it's more targeted. What do you think the percentage is of women suffering from PMDD in your clinic?
Say the prevalence is about 3 to 5% amongst women who menstruate. Now, again, we've said that, there could be some sort of geographical and cultural variation, but it's prevalent. If, say 5% of women who menstruate can have PMDD. And the thing is, we live in such a stressful world now. There's so many other factors that affect our endocrine system. So we know, we're under a lot more stress. There's so many factors in the modern world that increase our stress levels. The working patterns, social media. We know that social media has an impact on our dopamine levels, which is another neurotransmitter that can affect mood. We have so many endocrine disruptors in the environment. There are substances in plastics that are around us all the time that have an impact on our endocrine systems. Pesticides also do. Cleaning products, personal care products, they're all endocrine disruptors. So when you're looking at PMDD, which is a hormonal imbalance that has an impact on mood, we have to look at these other factors as well. What are those things? Is this lady a cleaner who's exposed to cleaning products 24/7? Is this person a hairdresser or works in a nail salon where they're exposed to lots of chemicals? We need to look under the hood. What can be driving the hormonal imbalances? It's complex. It's never going to be one factor. That's why we need to look at all of those factors and look at modifying all of those factors that can then have an impact. Diet has a major impact. People don't realise that, food is the foundation of our health. So we advocate an anti-inflammatory diet to support good hormone balance. So a Mediterranean style diet where you have good quality proteins, good quality fats, less refined sugars and carbohydrates, and a very wide variety of fruits and vegetables that have lots of phytonutrients in them that are antioxidant for our body. For instance, cruciferous vegetables, they have sulforaphanes in them, and these sulforaphanes are really important for estrogen detoxification. So we make estrogen every day, but we need to clear it from our body, and the liver and the gut are important in clearing estrogen from our body. In the liver, we have enzymes called cytochrome P450, which are important for helping the liver to detoxify estrogen. Now, broccoli and other cruciferous vegetables upregulate this enzyme, which means that our bodies are much more effective at clearing estrogen from the body. And estrogen can also produce some toxic metabolites of estrogen. So these cruciferous vegetables help us push estrogen down the more healthy metabolism.
Some women swear by the raw carrot salad. They say that it helps them to flush the estrogen out and to feel more regulated.
Carrots have got high concentrations of vitamin A. Also, carrots have got a lot of fibre in them. So in our gut, we have a gut microbiome which is made up of lots of different bacterial populations. And these bacterial populations need to also be in balance. Now, the good gut bacteria love fibre. It's called prebiotic fibre. They love prebiotic fibre to chomp on, to then produce lots of metabolites that support the neurotransmitters, that support the integrity of the gut lining. So these healthy bacteria chomping on the prebiotic fibre are really important for our health. So obviously this lady's gut bacteria love carrots, and it's feeding her microbiome. So you have to look at your gut microbiome as like a garden, and you've got to feed it with healthy prebiotics to make it bloom.
Love that.
I was just going to add as well the importance of certain anti-inflammatory foods. So one of the other positive things that you can have in your diet is oily fish. So oily fish has high levels of omega-3, and omega-3 as well is a potent anti-inflammatory and can really support the body. And with women with PMDD, we also advocate a low histamine diet because histamine can also trigger off inflammation. And we also advocate a diet low in cow dairy because, again, cow dairy can aggravate the histaminic reaction, which can make PMDD worse. So, again, it's looking at this sort of multifactorial, multi-pronged approach as to how can we support this person's hormone balance and support their symptoms of PMDD.
And obviously no alcohol or cut down things like that, which increases inflammation.
Alcohol, basically, people can get what we call hangxiety. So alcohol in the short term can actually be a relaxant, but in the long term, it has adverse effects on the neurotransmitters in your brain. It can increase cortisol levels, and also alcohol is a toxin. It has an impact on your liver. So if your liver's busy trying to clear the alcohol, which is going to prioritise because it's a toxin, it's going to be less efficient at clearing your hormones, especially as you get older. And alcohol has an adverse effect on the gut microbiome. And so alcohol also impacts the gut. So chronic use of alcohol will also have an impact on your gut function. So, although it's very socially acceptable to drink alcohol, it really does need to be done in moderation. And moderation means moderation. I think people don't realise just even a small bottle of wine you can get in the supermarket has about 2.6 units of alcohol. And the ideal amount for a woman is 1 to 2 units a day, with a few days of being teetotal. So, for women who say, I have a half bottle of wine with my husband every night, that's 5 units, which is way too much. And yet it doesn't seem a lot, but actually in terms of the alcohol content, it's quite significant.
It's crazy actually when you think about it. Like when I was younger, like a teenager or early 20s, I remember watching Friends on a Friday night, and beforehand it would be Hardy's, the wine. The adverts would be just beforehand. So, you sit and you have wine to watch television. It just seems like such a weird cultural thing to do, but that's how I was raised, But it's interesting now in your 40s and 50s, women cut alcohol out.
It's fascinating as well. When I was growing up, there was only about 2 bottles of wine you could get: Blue Nun and Liebfraumilch or something, or that Rosé Mateus.
Hideous.
Yeah. And now when you go into Waitrose or Tesco, the abundance of different wines you can buy at relatively competitive prices means that it's a very attractive option. And it's also a glass of wine with dinner. Oh, isn't that nice? Well, yes, of course it is, but it's just, again, in moderation.
Yeah, it's interesting. So I've met people before who've initially thought that they have bipolar disorder, but it was only when they started tracking their cycle that they thought actually maybe it might be PMDD. When I was diagnosed with it, I was given fluoxetine, the SSRI, to take in my luteal stage of my cycle. I personally didn't like fluoxetine because it made me feel disconnected to my body and gave me the night sweats, and I just didn't like the other symptoms. But I know some women who swear by fluoxetine, who say that it's really helped them to feel better in that luteal stage.
So essentially, SSRIs actually also have a positive effect on the GABA receptor. So for a lot of women, the action of the SSRI can improve the action of the GABA receptor, and that's where for some women it can be really, really helpful. So again, we're looking at how we can use conventional therapies with a more integrative approach to give the woman the best outcome. So we know that the GABA receptor responds to supraphysiological levels of progesterone. So the GABA receptor is much happier with a higher exogenous level of progesterone. So if we give a woman with PMDD some progesterone in the luteal phase and we flood her GABA receptors, those GABA receptors are much happier than when they've got fluctuating levels that are normal in the natural menstrual cycle. And interestingly as well, some women respond to being on the oral contraceptive pill. So with the oral contraceptive pill, when we switch off ovulation and we have no luteal phase progesterone, GABA receptors also like having no progesterone in some women. It's really interesting. I saw a woman who I tried every single integrative approach on, and she said to me, you know what, doctor, it was when I was on the pill that I felt much better, and I tried everything, and then in the end I went back to putting on the combined pill because it was having such an impact on her quality of life. Now the thing about the combined pill is that it has a synthetic progesterone in it called progestin, and progestins actually can have a negative effect on mood. So you've got to look at the individual woman and how they're responding. The other thing is that natural ovulations, we know, are really important for our long-term health. So, actually the long-term use of the pill isn't particularly beneficial, but we always need to balance up what are the priorities for this woman and what are the best solutions for her particular situation. It's not always black and white, and we have to understand the nuances. The other thing about women with PMDD and an SSRI is that normally when you take an SSRI for depression, it normally takes about 2 to 3 weeks to have an impact in women who are going to respond to that SSRI. Whereas in PMDD, you can actually use that SSRI just in the luteal phase, and it seems to, for some women, have a beneficial effect, and that must be the impact on the GABA receptor. But if you give that woman an SSRI plus some bioidentical progesterone, you might get a synergistic response where there's even better control of symptoms and management of symptoms. And then we talk about women who have pre-existing psychiatric conditions will have a menstrual exacerbation, so they will feel worse in the luteal phase. But with bipolar, you have this switch between being completely fine and being a bit euphoric and then feeling quite profoundly depressed. Now, that happens in a woman with PMDD across a cycle. So it's like 2 weeks in, 2 weeks out, 2 weeks in, 2 weeks out. So yes, some people might think, oh my God, those kind of mood swings, it must be bipolar. But it's only until you map the menstrual cycle that you can see, is this linked to the menstrual cycle totally, or is there some other underlying factor? So someone can have an underlying mental health issue, but bipolar, definitely, with that swing in the mood, people can then misdiagnose that PMDD as bipolar. But again, there's an overlap, and if you have been suffering with PMDD over a prolonged period of time, you can develop depression because it's like a no-win situation. It's so frustrating to feel that 2 to 3 weeks out of every cycle you feel absolutely terrible. You're anticipating that change. Even in the week where you might have previously felt okay, that anticipation of feeling absolutely dreadful can be quite depressing and can lower the mood. So any kind of condition that is prolonged and undiagnosed and not validated and not treated will lead to someone's mood becoming depressed.
And it's interesting, actually, because when you're talking about it, you need to think about how can a woman survive and make money if for 2 weeks a month she is either suffering from severe depression or anger or anxiety or insomnia. So she might wake up at midnight, unable to get back to sleep. How can she hold a job down? And what I find interesting now is, and maybe it's because the World Health Organization have classified it as a real disorder, that you can now apply for PIP, because it is a disability, because it will affect their ability to earn money.
Absolutely.
And to function.
Yeah, it has a profound effect on function and also on their relationships. So, if you're going to have severe psychiatric type symptoms 2 weeks of the month, it's very hard to hold down a relationship because you're so unpredictable. It has an impact on your marriage, your relationships, your children, your work colleagues. So it also has a profound effect on other aspects of someone's life, but it's so important to make women realise that there is help out there. It does need to be assessed by someone who really understands the nature of PMDD. You know, very often people will go to a conventional medical clinic and they'll just be given antidepressants, you know, and that's it. Antidepressants, that's it. No one's really looking at what is driving these symptoms, or they'll be given HRT, blanket HRT. And again, you know, blanket HRT is not the solution, because we need to look at the individual variation in hormones. And then the other thing is, you know, when we've got HPA axis dysregulation, we have to help that patient understand why they've got the HPA axis dysregulation. So that understanding of their narrative, playing it back to them, making them understand that it's not their fault. You know, it's their environment they were brought up in, it's the adverse childhood events that have caused this HPA axis dysregulation, which is affecting their health. You know, it can be such a validating moment. You know, even that validation can be very profoundly healing. And then when women realise that, you know, their symptoms could be driven by unresolved trauma, then we can also help women with trauma-informed approaches like EMDR or psychotherapy to help people unravel what is causing their symptoms. So, you know, it's not a quick fix. You know, when women have got profound trauma and it's very embedded in their nervous systems and their bodies, it's not a quick fix. It takes time to gradually unravel all of those layers of the onion, you know, but by supporting them nutritionally with bioidentical hormones, really understanding what's going on, supporting them with supplements, herbal medications, mind-body approaches, you can help them feel better, so that then they're able to then have the resources to then dig deeper and to you know, potentially uncover unresolved trauma. So, you know, very often you need to, you know, open the door for them in making them feel better and understood before they're going to be prepared to walk through that door.
Yeah, so for me, so working on the unresolved trauma was a complete game changer for my symptoms. So obviously I'm a certified tension and trauma releasing exercises provider, neurogenic exercise, neurogenic yin, which targets the HPA axis. It calms the brain and the overprotective mechanisms, taking you out of that stress response. And for me, I'd gone to get therapy for my trauma. I had no idea that it would help me with my premenstrual dysphoric disorder. And I kept on saying to my mentor, my lecturer, and head of TRE UK, why is this having such a profound effect? Like, this is a game changer for me. It's so weird. Like, I've felt normal. I felt normal in my luteal stage. Why? I guess that's why I've done so much research on it, because it has been a game changer. But I need to self-regulate those symptoms, so I still need to do neurogenic tremoring. So it's trauma-related. So it's very interesting.
So it's helping people understand...
It's complex post-traumatic stress disorder.
Yeah. Helping people understand what are those triggers, and that, you know, sometimes you may get re-traumatized, and then how to break that cycle, you know. And it's an ongoing process. You know, when we think, can you cure PMDD? I think if you've got an actual diagnosis of PMDD, it's not about curing it. It's about helping you rebalance the body and helping you regulate it, and helping you understand what are your root causes and what can you do about modifying those root causes to help you heal and to help you have better symptom control. So understanding and education is also really, really important.
I've just got one more question for you. So how would a woman go about getting a diagnosis? We've talked about tracking the cycle, but for how many months should the woman track it before she goes to the doctor?
Well, presumably, if you start tracking your cycles, you probably have these symptoms going on for quite a while. So I would say, you know, even from your history of you thinking that there is some kind of cyclical variation, that's an important point. But I would say, you know, even tracking it for a couple of cycles, we say that you should have symptoms in the luteal phase of your cycle that are significantly better at the start of your menstrual period for at least 2 cycles. And there are 5 out of 11 sort of symptoms that are typical of PMDD that you need to have to make that diagnosis. So those are things like adverse mood in the second half of the cycle, physical symptoms like breast tenderness, joint pains, insomnia, hyperarousal, anxiety, depression, feeling that you can't cope, food cravings. So there are a gamut of symptoms that can be related to PMDD. So you need to have at least 5 out of 11 of those symptoms, at least for 2 cycles, 2 consecutive cycles. But as I said, it's really important to have a doctor who understands PMDD. Very often, a psychiatric evaluation might also be important, because psychiatric disorders and PMDD can coexist. So we need to eke it out, we need to separate those things out. And remembering that we can develop psychological illnesses at any stage of our lives, which will exacerbate PMDD if we have it in the first place. So someone who really understands you, really, and someone who's going to take the time to take a detailed history. In the functional medicine, we spend 75 to 90 minutes on an initial consultation, which is a real luxury, but actually it's totally essential to understand a complex history. A lot of people don't even realise that their childhood experiences were traumatic because they were so normalised for that child that they don't understand that actually that was pretty traumatic, and that's why their HPA axis is dysregulated. And we have amazing ways of measuring this in functional medicine. So we have tests that we can do that look at how much cortisol your adrenal glands are producing, how your body's processing that cortisol, and what your pattern of cortisol production is during a day. And it's fascinating because, we can see those abnormalities on the tests that we can do. One's called a Dutch test. There are adrenal stress profiles that we can do that actually validate that patient. You can say, look, this is the data. This is what is happening to you. This is what has happened to you. And that can be so helpful in that validation of what actually has gone on and helping the patient understand what has happened. And then, we're on a journey to healing.
I've loved our conversation, by the way. Thank you so much for coming on. How do people contact you?
So people can contact me via the Marion Gluck Clinic. So you can go onto our website. I have 9 other colleagues who are well trained in managing women with PMDD. We all have training in functional medicine as well. So there's plenty of doctors who are available who are qualified in understanding PMDD, how we assess it, how we make a diagnosis, how to access other treatment modalities. So, if I see a woman who I think needs a psychiatric input, then I can help that lady find that. Find a psychiatrist who's suitable and who can help them. Sometimes there may be hormonal imbalances that will respond very well to nutritional therapy. Gut dysbiosis and adrenal dysregulation also have lifestyle modifications that need support. So I often refer to a nutritional therapist. So we have a referral network as well. Acupuncture can be profoundly beneficial for the HPA axis. Bodywork. You, Allegra, I can refer people to you and to the resources, your fantastic book. So there are so many different ways that we can support someone with PMDD, but the doctor needs to have an integrative approach with a good referral network as well.
You mentioned you might be writing a book. Have you started that?
No, I do have quite a high clinical workload because there are so few clinics in the UK that have this kind of integrative approach where we're trained in functional medicine, but we also have a real expertise with bioidentical hormones. So, I run the Marion Gluck Training Academy 2-day in-person trainings at the Royal Society of Medicine. We do that twice a year. And so, we're busy always teaching other practitioners how to use bioidentical hormones. Myself and the head of the Marion Gluck Training Academy have just been to Miami on an A4M conference on bioidentical hormones. So our next job is to update our slides with the latest research for the next training that's happening in April. I think what I'm really interested in is the trauma-informed basis to managing hormonal conditions, because in my work I am seeing this constant theme of trauma. And I think it's so misunderstood by conventional doctors. Adrenal dysregulation isn't even a thing in conventional medicine, and so I think that there's a huge need for people to really understand that connection. So yes, I know I need to do it. It's just carving out time with a busy clinical workload and leading the clinic that means that I don't have time. But I have started making notes on interesting cases that I'm seeing, that might form the basis of the book. I'm thinking actually case studies can be a great way of illustrating this. So watch this space, Allegra.
Well, when it does come out, once you've got the time, I can't wait to read it.
Oh, thank you. Thank you.
Now, I have a huge favour to ask. If you've liked what you've heard, if you feel like you've learnt a lot, I would really appreciate it if you would like, follow and subscribe to this podcast, and also share it with anyone who you know or you feel might benefit from listening to it. Until the next time, goodbye. You've been listening to the Brain and Body podcast with Allegra Foxley. Thank you for listening and thank you for your support.